Good afternoon, everybody, and welcome to a special edition of our weekly COVID webinar. I've lost track of how many of these we've done now, but we've looked at all sorts of different areas of the NHS and the response to COVID. And throughout the course of the weeks, we've had people getting in touch with various questions. So rather than replying to those individually, I thought it might be a good idea to look at some of the biggest themes that have come through with a bit of a multidisciplinary team we've got here today. So we're going to have a bit of a panel discussion around some of the biggest themes, some things that we probably haven't really addressed over the last few weeks, which promises to be very exciting and insightful, and hopefully will add a huge amount of depth to the knowledge we've already helped you to gain about the COVID response. We're very lucky today. We've got the Fantastic Four. We're joined this week by Cameron Ward, Interim Director of Strategy and Outcomes at Sefton CCG, Hilary Snowdon, who is the Management Lead for West Northumberland PCN, Patrick McGinley, Head of Costing and Service Line Reporting at Maidstone and Tunbridge Wells Trust, and Dr Su McCole, a GP and Area Clinical Director in Sussex Community Foundation Trust. I think I've got all of those right. That's half an hour taken up. So the first area we're going to look at this week, we're going to look at the care delivery and how that's all changed and what might continue to change. And I think that the biggest question on a lot of people's lips is around how services are going to start to remobilise themselves, particularly with the threat of a second wave looming large in the background. So who should come to you first? Cameron, as you're at the top, shall we come to you first on that? What are you seeing locally about how services might get themselves up and running?
Thank you, Tom. So several things I would say to pick up with. There's a backlog of elective planned cases to consider, so we need to think about those. There's urgent and routine to consider. Some of the urgent cases have been able to be managed during the COVID pandemic, the first wave of this. Concerns about the elective routine waits, their waiting lists have increased significantly. We're also concerned about a great deal of unmet need, particularly cancer. Some other patients are A&E attendances have reduced significantly, attendances GP reduced significantly, others slightly creeping back up again. So I just think there's a huge unmet need. Outside of acute hospitals in the community and mental health, a lot of those services have been stood down in order to focus on COVID capacity. And so they're coming back as well. So we're trying to clinically prioritize those as best we can. But a third concern would be how long it's going to take to try to meet the unmet demand that we've had for the last 3 months. So those are the areas that we're looking at the moment. Happy to expand later, but those are just some initial concerns. Thank you.
Yeah, brilliant. Thank you. And Sue, building on that from your perspective, I suppose, what are you doing in that area around the remobilisation?
So I work for a big community trust, and we have both primary care and lots of community services, some consultant-led and all the nursing and things. And we were told very early stages to stop anything that wasn't vital. We have recently been told to restore is the buzzword. So we are going through all the services that we paused. Some of them were paused because NHS England specifically told us they were to be stopped, and some were stopped because you just can't do it remotely. We redeployed lots of staff into other services, and we stopped using agency, and so it's a massive operation now to go through all the paused services, put the staff back, and then help them work out how they can safely see people. I think our busiest team is probably estates, because all our waiting rooms were wrong, our clinical rooms were wrong. It's a massive endeavour. So I agree with Cameron, we have got a huge backlog. We've rejected a lot of GP referrals into our community services, so we know that they're going to come back. But more than that, of the ones we know about, we just don't have the setup to see them yet. So we're having to go through every single service and look at staffing, waiting rooms, access, PPE. It's a nightmare.
Thank you. And Hilary, how does that reflect in primary care?
I think it's very similar in terms of it's not just a case of restarting, because it's going to be very reduced capacity to be able to deliver. in terms of patient safety, staff safety. How do you ensure that rooms are safe while still being able to provide a service for people who are showing COVID symptoms? So, you know, we're really needing to start to think about across the locality, not just at practice level, what can be done safely with it, what has to be done within individual practices, what could be done remotely, what could be done by somebody else, does it have to be done by that patient's GP? So I think it's giving us an opportunity to really think innovatively about redesign, but I do worry about a massive wave of unplanned care in terms of, you know, all the screening services that haven't been able to be provided. How do we catch up on long-term condition reviews safely? It's a massive ask.
Yeah, okay, thank you. And Patrick, quickly on the hospital perspective on getting back to normal, how does that look from your end? I know we've been struggling a bit with your sound, Patrick. Can you hear me?
You're back now, Tom. I have been struggling a little bit. I think I'd probably just echo the points particularly Cameron made about our worries, but also Sue's point about the instructions to restore or restart. And the problem for us would be that what we want to restart would be in a completely different way, a different form than what we were told to stop. So as Cameron said, our urgent surgery for cancer is undertaken in Queen Victoria Hospital in East Grinstead and in the local independent sector hospitals. It's not being done on site.
Patrick, I think we might have dipped out from your sound again. So just gonna pause Patrick there for a moment. And I think what's come out of all of your responses there is kind of this split. There's two elements really. There's a bit about the practical element of how it's going to be done, but then also the piece about prioritizing and what Patrick mentioned there, you know, the question of whether what's being restarted is different to what was stopped. So in terms of that piece about sort of the elective and the routine care in particular, how is that going to be looked at? How might the prioritization go around there? I'll come back to you, Sue, on that if I can.
Yeah, I mean, our local acute hospital, similar to the one, Patrick isn't too far from me actually, I don't cover his area, but it's a similar idea. And us as a community trust have a wide range of services. And although NHS England wants us just to magically clear the waiting list and go back to normal, we can't do all the services in the new post-COVID world. So our acute trust is having to think carefully about who needs to be seen or have an operation and what's the safest way of doing that. We've got a 2-site hospital trust, which is quite common across the country, and I think they're going to do a red site, green site, so that they don't let anybody with symptoms onto the green site. And Patrick's quite right, cancer and some other surgeries are so high risk that you wouldn't dream of doing it on a site where they could get infected. So I think there's going to be more and more acute trusts who go out to the private sector and buy a small amount of capacity to kind of put really high-risk patients in a protected bubble. Community services, we're going through all our demand and thinking, well, who needs us most? So for example, we do all the local child health. So the Healthy Child programme is vital for picking up the most at-risk children. So we've prioritised getting the Healthy Child programme back on, and we're also starting to push immunisation because flu season's coming, and if we don't get everybody immunised against seasonal flu, this is just going to compound. So I think we're being told do everything, but we're being allowed to plan according to what we think will actually give us enough breathing space to then bring more things online. And we're bringing them online in sections so that we aren't overwhelmed, because the NHS was supposedly going to be overwhelmed by COVID, but as I said to you before, Tom, on other conversations, I think the NHS is looking at its worst overwhelming coming up, because when we start trying to clear these backlogs, that's when we're going to go under, because staff are tired and weary, and then they're going to get this massive bow wave of unmet need.
Thank you. And in terms of that bit about prioritising, you're saying you're doing bits in chunks and you're being asked to do everything. Is that prioritisation by clinical need, or is it by the way you're incentivised or reimbursed for certain activities, or how is that managed?
Some of it is to do with what we're being told to do. So, for example, the listeners will have heard about the GPs having to do enhanced health in care homes, and community trusts have to be key to that. So we've got an entire team sorting out getting our part of care home MDTs up and running. So sometimes it's prioritised by what we're being told to do, and then with everything else it's being prioritised by the local team. So the area that I run, I'm a doctor, we have an area nurse and an area manager. The three of us sat down, looked at our services and just said, well, we think that should come back online first, then that, then that. Sometimes it's the longest waiting lists, like physio, and sometimes it's because emotionally that's what we think our community would want, like children.
Yeah, okay, thank you. So Hilary, I saw you nodding and shaking your head at various points through a couple of those responses. In terms of primary care and how you'll be prioritising the return to well, or remobilising, how are those decisions being driven in primary care?
I think as a group of practices, I think there's things being done across the locality. But at the same time, individual practices are deciding how to prioritise. But certainly I agree with Sue. I mean, childhood IMS is going to be key, because we're really concerned, that if people don't come in, actually we're going to have a worse, epidemic. And seasonal flu is, you're just thinking we need to, normally in primary care what you have is a Saturday morning where people are queuing around the block to have their flu jabs. That is just not going to be feasible going forward in a socially distant way. So it's going to take a lot more time, which is great if the weather's with you and you can do it outside. What if the weather's pants? And so we really need to think innovatively, but we're expecting demand to be high for flu vax. I think I mentioned long-term conditions, and I think it's also prioritising people within those. So, for example, with diabetes, beforehand, you might say everybody with HbCA above 58 needs to be seen, but actually that might be so many. So we say, right, those above 64, 70, we prioritise those. I think there's going to have to be some stratification in terms of patients. Which is, from a sort of operational point of view, is going to be quite challenging for practices, because normally those reviews are by the month of the month that person is born in, and we're going to have to do that differently now. So I think what we're trying to do is across the whole PCN try to get some agreed principles on how that's done across all the practices, because what we don't want to drive through is inequity further than it might already be.
Yeah, thank you, Hilary.
And Tom, I just wanted to add that I think there's both opportunity and risk now. There's opportunity that we'll all innovate and redesign things that didn't work, but there is risk that we'll all start pushing work at each other, because if you've got acute trust, community trust, GPs and the CCGs overriding but being held account for something they don't really control, there is a risk that we will all go back into our silo camps. And what made me think of it was flu vax. Our community district nurses give out thousands of flu vax, but we only do it for housebound patients, and we've had this massive rush of lists of patients that are now apparently housebound that are now become our responsibility, whereas in the past the GPs did it. So there is a risk that we're all going to go into our camps and throw this extra work at each other and break down the relationships that were just starting to blossom. And NHS England's going to make that worse by holding the wrong people for account for the wrong outcomes, which is what they tend to do a lot.
So Cameron, coming to you as the Commissioner, how are you going to coordinate everyone and make sure they're pulling in the same direction to get all your priorities, I suppose, at a population level.
Okay, they're going to do exactly as we say. And if they don't agree, we'll have a nice little chat, and then after that, then they'll agree that we were right in the first place. Just in all seriousness, all right, I know I'm being flippant. I think it's important because actually both Hilary and Sue have talked about actually what there's a significant tension here, I think, in the system across the country. There's a command and control system in place with hospital cells, out of hospital cells being set up. We've been talking locally that actually it needs to be a system approach. It can't be separate in that way, so that's unhelpful. Because across the area that I'm in, that's Cheshire and Merseyside, that's a population of about 2.8 million. And they're talking about common waiting lists, common approaches, and really that's just far too great a size. So we've got a tension there because the trusts and the community providers are going to those two cells, as it were, talking about things. And the CCG then are in the middle in order to try to make that work. The concern as well is that the constitutional requirements around 18 weeks, 52-week waits will get a lot of attention, when really it's all the other things that Sue and Hilary have talked about. Mental health and all different aspects of mental health as well, CAMS, immunizations have been mentioned, all of those things actually I think should give a greater attention, which is going back ironically to the NHS long-term plan, and that's about addressing health inequalities. So I've just got a concern that all of those local issues where we're getting local authorities involved will just come across this. It's going to be a command and control system. The other thing to note is I know we're not going to be talking about dentistry today, but there was talking about dentists on the radio this morning, and I couldn't believe, first of all, that they aren't identified as frontline staff. They've been closed for several months. They don't have PPE, and patients are doing their own dentistry at home, and that's like dark ages things. And we're talking to people. So I just think some of the priorities we haven't got in the right place. And I know that there's going to be some national discussions later on this year, over September time, about resetting those priorities. But I think really we can reset them now. And that's exactly the things that Hilary and Sue have talked about. That's where we need to be focusing our energies, I would think, particularly to address the health inequality aspects.
Yeah, brilliant. Thank you. Patrick, have we got you on audio?
Yes.
We have. Fantastic. Could I just come to you to ask at a trust level, in terms of the prioritisation of services and remobilising them, what are the considerations for you in how you address that? What comes back first and what ways?
I think there's I think, as Cameron said, there's a real set of tension coming in, and it echoes many of the points that Sue and Hilary made as well. From an operational point of view, we're looking at elective and planned work and kind of saying there's four buckets. There's the must do and can do. So we can do the oncological surgery off-site somewhere else. So we do that. Then there's a sort of should do and can do. And we're thinking about how we do that. And that's where, some of those difficult words for an accountant come in terms of the ethical judgment there. Do we make the emotional thing? Is cancer always more important than varicose veins, to throw one? There's a third bucket of can do, should do, but can't. We don't have the capacity, we don't have a method, we don't have a formula. And there's that horrible fourth bucket that we can't, and maybe we shouldn't. And we don't know what's going in those, so there's an operational issue there. But I think there's a value tension. If I have a resource in theatres that is really, really precious now, because trying to get a surgeon and an anaesthetist in the same place when there's lots of other pressures to pull them away is even more difficult. But if I'm going to spend half an hour between cases, I kind of want to spend as few half hours cleaning up as possible. So do I look at cataract surgery and go 9 minutes operating for 40 minutes cleaning? Do you know what? Moorfields have almost stolen a march on that locally, that they was given notice to withdraw services from North Kent. And just as I announced yesterday that this was absolutely the area we should be avoiding, we had the Director of Operations saying, no, we've agreed that we'll pick that up for North Kent. Well, marvellous. But there is, if I'm going to have difficulty getting people in the same place, do I really want them standing around for more than half the time, not doing what we want to be done? And
so is your feeling then that the elective work is going to take quite a long time to gain momentum?
Yes.
Then, because there'll be I suppose almost an inertia around value judgments and everything that goes on.
I do, and in my quiet moments of despair, which for an accountant come every day, there is an existential risk to the DGH model. It's fine saying I can have a red and green, but my anaesthetist will be on the red site in the morning, and a surgeon will be looking for him to be on the green site in the afternoon. And I'm like, quite sure that I can't protect the green, so I actually think we stop having that 2 A&Es, 2 surgical sites, and that's maybe not a bad thing, but that's a command and control issue that says, Maidstone, you're green, you have no A&E anymore. So it's a bit of a shame that we've just appointed you to be the HAZU.
Yeah. Okay. Thanks, Patrick. Cameron, were you looking to come
Sorry,
in?
just a small PS to that. Actually, interesting, we're finding that because of the 14-day self-isolation that prospective patients need to do before they go in for their elective surgery, quite a number are now saying, well, no, actually, they can't afford that because actually they're back to work after being furloughed.
Yeah.
And also they've got a concern, actually, that even being self-isolated, they don't want to go into hospital in case they get COVID. So that just brings in another dimension to how it might downplay some of the elective work. So I didn't want to take up more time, but it was just thought it was quite relative. Thank you.
Thank you for clarifying that, Cameron. I think we've got a good picture there of kind of what might lie ahead. Another one of the questions that I think follows on nicely from that, one of the questions that's been sent in was, what lasting relaxation effects on NHS government do you anticipate remaining post-pandemic? And I suppose that's a reference to the green light that's been given to expenditure and doing things, a lot of freedom given locally to addressing the pandemic. I can see lots of smiles up for this one. So, what's the perception on how that might last? I'll come to you first, Hilary, if I can do from a primary care perspective.
I think it's going to come back and twice as hard to an extent. I think we've been allowed to really do things differently, and the governance is now trying to catch up with that. Certainly there's been a few safeguarding issues I'm aware of in terms of consultations and sending images across, and I just worry that it's sort of like we've been let out of our boxes to innovate, and NHS England and CQC will want us firmly back in our boxes.
Yes.
And it's sort of how do we ensure that doesn't happen, but within a safe governance, and that's a safe governance perspective, not just for patients, but also for staff as well. But I do have concerns it's just going to come back twice as hard.
Yeah.
Are there particular things that you think might be focused on? You've mentioned obviously their sort of safeguarding and some of those sorts of issues.
I think information governance, certainly at the start of COVID, the Information Commissioner had said that she didn't envisage any instances where people would be prosecuted if they were sharing information for the right reasons. That's not going to suffice going forward. And I think there's a real concern about, are there going to be complaints about things that you did at the time? And it's how will that be judged? And I think that's going to be a moving thing. And so I have a real concern that people were doing things at that time for the right reasons at that particular day and time, but somebody's going to judge that as being not the right thing at the right time later on.
Yeah, thank you. So Sue, same question to you. What's your view on the governance situation?
I think Clinically, we've been given a lot of leeway. Doctors are being, well, all clinicians are being allowed to work outside their area of specialty, and we were all given special indemnity to cover any mistakes we made because we were dabbling in something we didn't really know what we were doing. There is a lot of anxiety that people were pushed to make decisions they don't normally make, and as Hilary quite rightly says, is there now going to be a going back over what we did and looking for flaws? I think we've also been given the green light to be very innovative and do things in different ways. So we're using various software and we're ringing patients, we're doing all this stuff. But it's a little bit dodgy. I mean, for example, my son's teachers aren't allowed to have a one-on-one video conversation with him because of safeguarding. But a GP can ring a patient who might be mentally ill, vulnerable, whatever, without capacity, and have a one-on-one with them. So I think it can't stay as relaxed as it is. The government needs to get control of money, needs to get control of what we do, what mistakes we do or don't make. They also let us bring loads of retired staff back with tax relief, and they can still claim their pensions, and all those staff are going to retire. They've put lots of clinicians working from home because they're shielding. What they're going to do about that? So I agree with Hilary. I think they're going to pick over everything. They're going to look for ways to not pay what they promised to pay, and they're going to look for ways of pulling the lead a bit tighter again.
Yeah, okay, thank you. And Cameron, I suppose you've already mentioned command and control, and I know from previous conversations you've got a view on that. What's your perspective on the governance overall?
I suppose my concern would be that it hasn't got to go back to what it was like before. And within the command and control environment, which Sue and Hilary have indicated, is they've given us some freedoms, but the danger is it'll go back to what it was like because they want that control, and that's what happens in a command and control system. And however, I do think it's negative. It can only be in place for a short period of time, and then you need to have that local arrangements in place. So we should be able to locally determine if things have worked. Let's just continue to make them work and not have to go back. So that would be a concern, because really a lot of decision making has been quick, which is good. Speed of implementation, fast, which is good. So we need to make sure that we continue to do that. The finance bit that you were mentioning as well, and others have too, before Patrick comes in from an accountant point of view, there's a bill here and it's going to be significant, and we can't ignore the fact that it's going to be very costly. So the emphasis around the money's not an object, it's very short-lived, and we have to get back, and it's the right thing to do, is to get back to thinking about how we can do these things, because opportunities have already been mentioned both by Hilary and Sue and Patrick. Actually, there are some opportunities, and we need to make sure that we can use them. So some of the remote working, the Attend Anywhere software, that's all good, and we need to make sure that we can capitalize on that, because actually that will give us some savings. So that's what we need to try to do as well. I just really want us to guard against going back to what it was like.
Yeah, thank you. And you've recognised why I was leaving Patrick to last there.
Yeah, yeah, exactly.
Patrick, can you sort of segue the governance piece into finance and give us a perspective on sort of how you expect the finance arrangements and the governance that sits around that to play out?
Well, I think it does segue from the points Cameron's just made, that the impact of the command and control has already started in the acute finance position. 18th of May, we had a letter telling us what would and wouldn't be funded as reasonable under the COVID. That blank checkbook has been withdrawn. If it's not on the reasonable list, you're not getting it, even if you've already paid for it. Equally, the PPE, only the centrally sourced PPE will be funded. If you've set up your own arrangements in addition to that, they're not funded, they're at risk for you, they're out of your block contract. So for us, that's £900,000 in May and the same in June. That's not funded. My concern on the governance issue is that given the leash is being shortened on finances, sometime in August there'll be a further announcement, and it will be much less money coming in through the block contracts, I suspect, but that the command and control approach from NHSE they may find it very attractive, and like catnip, it may be a little bit difficult to let go of in September, October, because I think we start then running into all of those earlier issues about flu immunisation, seasonal change, and at that point, there's a decision made by NHSE that that's the wrong time to let go on the governance. Absolutely right about keeping the things that work and making sure we don't go back to the position we were in, because that wasn't really working either. But I had an interesting conversation with a colleague in Germany last night, and they found that they're already back at 80% face-to-face consultations.
Wow.
And that's one of those ones that we're going, we must keep remote access. We must have, you know, a continuation of that. That's such a good thing to come out of it. And they're saying no.
Is that within a hospital setting, Patrick?
Yeah.
Yeah.
Yeah. You know, patients wanted to see face-to-face, and that was the driver. Now, it may be that as a, you know, largely insurance-based system, if you want to see your doctor, you've got a little bit more than us going, nope, you're not seeing any of our GPs directly. That may be different, but that was really bad news to get last night.
Yeah, absolutely. Yeah. You mentioned, or you've already touched on it. This, you know, you were given license to do things differently. Now it's all coming back. Do you perceive, I suppose, a detriment to trust? Because early in the COVID crisis, everyone was talking about trust was building and partnership working was better and collaboration and everything. Does anyone perceive a deficit in trust as a result of this tightening of governance? Anyone want to jump in?
I think there's a detriment of trust between us and NHS England.
Yeah.
I think not between us and our colleagues in community and acute.
Yeah, thank you. Everyone looks like they're...
Yeah, no, I would agree. I think the local collaboration has worked very well. Local authorities, community, trust, mental health providers, along with acute primary care. So that local collaboration, I think, has been very good. And I would concur with Hilary about the NHSE, but I can link it again to the command and control.
Yeah, okay, thank you. So, I mean, you mentioned there the collaborative working locally, and everything we've heard over this sort of series of webinars so far has been very positive in terms of how that's all working. With a bit of a nod to some of the things that we've heard, particularly from Patrick there as well, about reversion to type. Do the panel see that this is a big step forward in kind of the integration, and that there's lasting change there in how the partnership working's all gone? Sue?
I think at the moment we're in a good place, but I'm not sure it will stick. So district nurses at the moment can go into a GP surgery and enter things onto the records using their computers. There isn't really the information governance signatures on the right pieces of paper for that to happen. I'm not sure that will stick. And I think when we're all tussling to try and clear our waiting list before we get penalised, I think we'll start pushing work at each other, and that puts tension on these relationships. So I think the other thing is that the public have been very NHS friendly initially, not quite so much clapping now, but when they realise they have to wait a year to see someone about their gallbladder pain, I think all that goodwill is going to fall away. And then the NHS staff will be under horrible pressure from patients, and that's when the bad behaviour comes out.
So Cameron, just I suppose question for you there, you know, having the commissioner perspective on, I suppose at that point that it becomes difficult, there's a choice of, do you look after yourselves as a part of the system, so primary care hospitals, or do you look externally to collaborate? How do you support the move towards collaboration rather than reversion?
So first of all, I think it's important that we do give every evidence and message and signal around a collaborative approach. That's what we need to look at, and it's regularly questioning that within the system. So it's really trying to build on that. I think there's a lot of goodwill, and we just need to try to keep hold of that. So it doesn't have to be the CCG. We're in a situation whereby anybody in the system can take a lead for things. We just need to continue to make sure that we work together and it's a regular emphasis about that. So if the likes of the CCG are regularly collaborating, sharing documents, being open and transparent with all parties, then that continues to build that trust and ability to work together. And the final bit for me would be to say, well, if we've all agreed that that's what we're going to do, we need to be able to call out when people aren't operating in that way as a reminder and a check. And if that's for the CCG, that's fine, but then anybody in the system can do the same thing. So that's how I would be trying to encourage it.
Yeah, thank you. Hilary, that piece around collaboration and partnership working has a particular connotation in primary care, obviously with primary care networks still fairly embryonic or certainly not mature in most parts of the country. Do you think there's a lasting impact of COVID on the progression of PCNs? And obviously there's still question marks around I suppose the long-term sustainability of them and question marks over some people signing the DES.
I think to some extent COVID has been the making of PCNs, and none of the COVID response was part of the PCN agenda. You know, there's been no additional monies at PCN level for any of this, but we were tasked with having a locality-wide response to COVID and how to provide sort of hot hubs for patients with COVID-like symptoms, how to do that safely to enable practices to continue, you know, to function for their own patient population. I mean, it came very strongly for us when a partner for one of the practices had said to our clinical director, I hadn't realised actually until now how much I feel as if the PCN is a bigger family for me, and they felt really supported. And that's really important, particularly in our area where there's massive rurality, and it's, you know, and especially if people are working remotely, that just reinforces that isolation. So it's been really important. And I think up here we haven't. There hasn't been the rumbles that there have been in other parts of the country in terms of don't sign the DES, because to be honest, I think it's really difficult to argue against why would you not want to support and provide good care to those people in care homes. Why would you not want to ensure that people have, you know, had structured medication reviews? Why would you not want to make sure that cancer's being diagnosed? Yeah, you can't argue against that. If that's what you're supposed to do. I think if you're saying, oh, we don't agree with that, I really think, well, why on earth are you in primary care? To some extent, because that's what we're about. So I think it's really, the COVID's really galvanized that way of working and being able to show that actually it's 12 or 14 practices. We don't have to travel together to make decisions. We can do it remotely and make decisions a lot quicker, and we have that trust in each other to do things.
Yeah, thank you. And Sue, I can see you're nodding away, obviously as a GP in a community setting now. What's your take on sort of the collaboration with primary care and I suppose the future of primary care networks or the impact of primary care networks?
I think change has always needed a burning platform, and COVID was a good burning platform to get a lot of us moving. For us, the Enhanced Health in Care Homes DES is yet another burning platform. So as a community trust, we are now talking to all the PCNs about what do you individually need, and the fact that we're asking them what they need and giving them what they need builds that relationship. So people talk about building relationship. You can't do it theoretically. It's not about going out to dinner. You've got to have a project that you work through, deliver, build a bit of trust. So I think COVID was one, didn't necessarily get cross boundaries going, got the PCNs going. I think the next one is going to be all the PCN DESs, which comes with a healthy dose of it's not fair, which brings people together in the NHS beautifully. If you get a room of clinicians all moaning about the same thing, that'll galvanise them. So I think we've got an opportunity, and I think it's also a good opportunity for industry to get involved in the NHS and change their perception within the NHS, because we're being given something unreasonable to achieve, and we're all very affronted about that. And if somebody swoops in and offers to help us, then we're going to remember that. So it's an opportunity.
Thank you. I think we might come back to that point in a minute or two. Before we do, I think Patrick, you've already referenced sort of a couple of times your work with the private sector and possibly them having to play a greater role going forward. Can you just talk for a minute or two on how you've been working with the private sector and the role that you'd see them playing and how kind of the interactions work?
Yeah, and this is quite an interesting time as we look at the sort of restore, restart. From an operational point of view, the beginning of the crisis was perfectly handled through command and control. We got a block contract for not doing work, and the independent sector contracted directly with NHS England, and they got a block contract for doing a little bit of work. And this is part of the bill that we've all mentioned before that will have to be paid back. What has become clear as we've reported the first couple of months' financial position, and shockingly, it will come as no surprise that with very few patients, reduced levels of ED, no planned elective work in Maidstone and Tunbridge Wells, we still managed to make a loss in the first 2 months. So proving that patients aren't in the problem in any financial system, it's us. But we've looked at the amount of work that we lost in month 1. That's all the figures we've got at the moment. And if we'd done it on a PBR basis, we would have been £20 million short in month 1. So £240 million in a year when our budget is £515 million. So that's a scale of the amount of work that we've lost. Now, when we look at the independent sector activity levels, they've got nowhere near that level of work going through the independent sector. So a number of things come up. One, we've been triple paying for the work that we've done. That's entirely possible. Two, the independent sector haven't done what they said they would do in terms of making the returns on the level of activity that they would. That's also not out with the bounds of possibility. Well, three, they have done it, and we've still got an enormous gap between us. And at that point, what do we then do to put that right? And we've started as part of the restore saying, right, well, we'll carry on doing the oncological surgery at Queen Vic. That's fine. That's part of the NHS family. That's fine. As we then start to go, right, well, we want to stop doing orthopedic work at KIMS. That's fine, except KIMS have got a direct contractual relationship with NHS England, not with us. NHS England have contracted that work, not us. So we can say we want to bring it back, and they can say, fab, we don't care. We don't actually know who owns that consultant time that's being done there. I know I'm paying for it. Pretty sure KIMS are as well, but that's just scurrilous speculation. But how we control that process is really very difficult, especially if the command and control continues. You know, can I hand and heart say it's safe to do orthopedic surgery at Maidstone? No, it's not. What am I going to do about it? Is it safer to do it at KIMS? Almost certainly, very probably. That difficulty in the relationship is we don't have that. You know, up until the 16th of March, we were the prime provider. If an orthopedic case needed to be done at KIMS or Benenden or Spire, it came through us and we agreed the case. Now it's directly through NHS England. They have done a deal. We send X cases a week. We choose those cases, but we don't choose who does them. We don't choose how they're done, nothing else. And we've lost that control of that relationship. And it would be really interesting.
And you're not actually engaging per se with those local providers then to say we need a bit of a hand with this bit or that bit.
No, because they're working directly for NHS England. You know, send us your arthroscopies. You know, we don't want to do anything more expensive than that. But we're not controlling that anymore. That was just taken away, and it's part of that command and control change. You know, and until it's handed back fully to us, we've got nothing to lever a relationship with the independent sector.
Yeah, thank you. So Cameron, just coming to you on that same point, I suppose, you know, with the commissioner hat on, when you're looking at the services or lack of services that are being provided across a CCG at the moment, do you have a role to play in determining who will be doing those and where they might go?
We will be, other than the independent sector that Patrick was referring to, because that's a national contract, used to be done to CCGs, but that's done nationally up until, I think it's about the 24th, 25th of June. At the moment, I would expect that to be extended to pick up the elective workload. But the rest, yes, that's very much up to the CCGs. The problem we have is that we've got, just like the acute sector, similar block contract funds. So it becomes difficult to then spend beyond some of the commitments we've already made. So that's what we're just trying to work that through at the moment. But I'd very much like to encourage, particularly the voluntary sector, huge opportunities there for them to do some activities and support us as well. And then that links you into the industry as well to think how can they assist with this too.
Yeah, and I might ask you to just carry on that front. One of the questions that we have been asked was, you know, around experience of working with industry throughout this, in, you know, not so much the independent sector, but broader than that, and where you might see opportunities for support that you're unable to manage at the moment.
Well, it's been quite limited from a personal perspective, but where I think they can add value, we've talked about finances already, is where they can think about the community-based services. So it's not going into hospital, it's an opportunity to just innovate, continue the transformation work that we have been doing, and for them to focus on that at a reduced cost. And I think that's where the greatest opportunities, I think, will be. If there's an opportunity for patients to be seen, treated in the community without having to go into hospital, I think that's going to be good. I know Patrick might be concerned about that in terms of lost income, but I'm trying to think about the overall demand that we have. And I think Sue already mentioned about, you know, further waves will get inundated. So I think that's where they could give the greatest assistance. Thank you.
Yeah, I mean, as you mentioned, the communities. So I suppose coming back to you on that bit around seeking support and getting more patients into community settings, do you see a place for support around pathway redesign and sort of that general area?
Yeah, I think there's a risk that the easy stuff will be cherry picked off, and that's always been what NHS England have done. They take the easy stuff and give it to the private sector, leaving us all the complex stuff. But I think going forward, we're going to have to work smarter and help from the industry to work out which parts on this pathway could be changed to get better results. Is it using different kinds of staff? Is it better empowering patients? Is it patient education? Is it group consultations? Is it, you know, webinars of giving advice? I think there's a lot that can be done, and there's a lot of technology out there, and NHS always lags behind that. So there's all sorts of things you can do with apps that we don't do at the moment. So I think there's a lot that can be done, and for each kind of system of the body, diabetes, respiratory, musculoskeletal, there's a different host of things that could be improved. And I think both communities and community trusts and GPs are going to need a hell of a lot of help. So now is the time to step forward and say, what do you need? And ask us what our fears are, and then facilitate us thinking through a potential solution, and just be with us on it. You don't have to have the solutions, but just be willing to help us think it through, plan it, work out how we're going to do it. How do we troll through patient notes and find the right people? How do we call them in? How do we track who's come in and who hasn't? I think the NHS needs more help than perhaps the industry realises. Perhaps there's an assumption that we can do things that we can't do.
Thank you. Hilary, have you got anything to add to Sue's comments there?
I just want to reiterate that actually, particularly I think there is an opportunity for pathway redesign, because the way cares can be delivered is being thrown on its head, you know, and what we considered had to be done in a certain way is being changed. Those thoughts, it's being changed completely. I think, you know, the role of things like diagnostics, you know, how do you provide care safely in a patient's home? What tests can they do, etc. And you know, I think there's a real opportunity use of technology, and Sue's right. You know, we don't have that, and enabling us to see that there are opportunities. And I think I see certainly GP practices are much more open to different ways of working now. And what we try to, certainly thinking about a clinical support unit for our practices, led by pharmacy technicians, that was raised in February. It was poo-pooed because, oh no, pharmacy technicians have to be within our practice, not remotely, not centrally. Went through it last week's board meeting because everybody realises actually the last thing we want is more people in the practice, but having a remote centralised unit will be perfect.
Yeah, thank you. And Patrick, to you on that as well, where would you value support, or would you value support, and where from external industry partners?
I'd just echo everything that's been said, and actually, especially the point Cameron made, that the challenge for acute hospitals now is, I think we almost have to prove, is it worth coming to see us? Is it worth being in an acute setting? And if it's not, we should be doing it somewhere else. And we shouldn't be saying, oh, the best healthcare is secondary acute care. Oh, I mean, it always will be, of course. But you know, we actually should be turning that on its head and going, steady. What is the need to be in hospital, rather than, oh, I've got a serious illness because I'm off to the Maidstone. Actually, why? You know, could we remotely monitor blood counts from home for chemotherapy, rather than, you know, oh, how do we get this result every 2 weeks, every 3 weeks, every 6 weeks, or whatever? That's where we need the help. As Sue said, or paraphrasing a part of what Sue said, you know, we need a lot of help that perhaps industry don't recognise, but particularly we need it in monitoring and recording. You know, we may be very good at setting up virtual clinics and whatever. We're rubbish at actually recording who came, who saw who, for who, how long. You know, we can do the first bit of the app, but not the bit that says, how do we prove it? Who saw who?
I mean, as an example of that, we run rheumatology in the community, and we've got lots of patients on toxic drugs. So they have to have blood tests every 2 weeks, which they haven't had for ages. And then those blood test results, the bloods get sent to the acute hospital, who analyse them, and then we have a secretary print them off one by one and put them on a doctor's desk to leaf through one by one. And you're relying on that doctor being alert and noticing that that number is higher or lower than it should be. There's no flag system. So in a GP surgery, it's all done electronically, and it kind of comes up a different colour depending on which system you're in to say that it's an abnormal result. So even something as simple as, we have to do Lord knows how many thousands of blood tests a day, and we are manually printing them and looking at them. Can you imagine the efficiency if somebody just generated some kind of algorithm that only printed off abnormal ones?
And I suppose a nod to your and Patrick comments there. One of the other questions that we've had sent in was, how will innovations that have happened during COVID be evaluated so the best ones are kept? So I suppose that's kind of picking up on the same bit. How do we know that this change has been positive? Hilary, I can see you're smiling there.
I'm smiling because I think NHS's definition of evaluation is probably very different from mine, and I would say mine's more robust definition. So yeah, that's why I'm smiling, not that I necessarily have the answer.
Yeah, okay, thank you. Cameron, how do we know what the good things are?
I suppose the bit here is that if we could do research for a long period of time. I'm not downplaying research, and it's important that we continue to do that. But if at this stage we think that something's working and the general consensus it is, and there hasn't been any serious risk or clinical concerns, then we should just continue, all right, and then move on to the next thing, rather than because we're just going to get bogged down in the whole bureaucracy of is it working or not, and whatever. And I just think that's going to be counterproductive. We just need to keep that momentum going. If it's working, great. Let's move on to the next thing.
Yeah, thank you. Sue, Patrick, any more comments on that?
And I think within my community trust, we've got an industry called QIA, Quality Improvement Analysis, and reams and reams and reams of forms have to be filled in for every change, every penny you spend. And we've stopped doing that because we can't keep up with the number of changes we're making, but we're going to have to go back and do it. So I think, how do we make the good stuff stick? Ideally, it's the PDSA, isn't it? Plan, Do, Study, Act. NHS doesn't ever do the study. We don't review because we're too busy fighting the next fire. So I think the most important thing is for us just to pause and look at what changes were made, double check that they're safe, and then continue. So actually to review them. But I would lay my income on the fact that the vast majority of trusts never review what they've done because they'll be too busy jumping through the hoops that are thrown at us.
Does that resonate, Patrick?
Absolutely, and I can't believe that both Sue and Cameron are being so heartless towards our CQC partners. What on earth will they do if they're not going to be reviewing what we did and looking through the QIAs to justify why we made the change? I mean, I think that's one of those really exciting opportunities that we can build on what's changed in COVID, that actually we kind of got used a little bit to, this is a good idea, let's put the show on here, kids. And you know what? All those people with good ideas, they had good ideas. And how do we keep that without somebody going, right, can I see your spreadsheet, please, that relates to the QIA for why you only did, and that's the bit we've got to lose.
You do a wonderful impression of yourself, Patrick.
I mean, the trick we found internally in Sussex is we just call it a pilot. If you call it a pilot, you can do pretty much what you like. You just have to have some key performance indicators that you're tracking in case somebody comes after you for it. So what we've done locally is we've branded all the changes pilots, which should trigger a review. And it kind of implies they're temporary.
And we touched on the governance piece. So when a pilot goes wrong under this permissive environment in which we're in, how can that be managed? How is that managed?
You just go back to the way you used to do it. It's completely forgiven. If it was a pilot, if every pilot succeeds, you're not taking enough risks. So if you call it a pilot, it's temporary, you're just trying it out, it's nothing too radical, you get away with anything. We've piloted leg ulcer clinics, catheter clinics, dressing pathways, all sorts of different things. And if it goes well, you just don't ever stop the pilot. And if it goes badly, you stop it and there's no repercussions.
Cameron, you're nodding away there. Do you agree with that?
Absolutely. We do need to take more risks, but they've got to be proportionate, of course. I agree very much about the Sue. If things are working exceptionally well, then you're not pushing the boundaries enough. And I just think we need to create that environment where people are in the knowledge that that's what's going to be safe for them, and there isn't going to be the repercussions, as Sue says. We just need to continue to create that environment, because that's the innovative environment we've had for the last few months, and that's the bit we need to maintain as well. Thank you.
Thank you. Hilary, do you think primary care has the appetite and the capability to work in that kind of a style?
I think it does. I think what I'll be very wary of is if it gets done in a way that where the CCG commissions something, and certainly I've been in a position where we've piloted something, it hasn't worked, obviously, and we've said to the CCG, look, this is a waste of resources, it's not working, and they've said, no, it was a pilot, we commissioned it for initial 6 months, you've got to do it for the 6 month period. And I think it's those sort of things, it's about nurturing innovation in a safe, constructive, enabling way, because it allows us to review, change if necessary, without having to go through 1,000 steps and 1,000 bits of form filling.
Brilliant, thank you. Patrick, can I come to you for a final word on managing risk?
Yeah, I'm in favour of letting people like Sue lead. I shouldn't be involved in what's good clinical risk or whether it's worth £5.66 every third Thursday. That's what's stifled in innovation and risk taking. You know, we should be saying, you're the clinician, what's good for your patient?
Yeah,
Will I
brilliant.
have that in
that's
writing, Patrick?
Absolutely. Invisible ink, signed last Thursday. It's in the post, Sue. It's in the post.
I think we've just hit 3 o'clock, so I'm going to take this opportunity to thank you all hugely for your contributions today. And I hope, Sue, that you're not in charge of the RAF's slogans at all in terms of pilots not doing their job unless they've failed. So thank you all. To our audience, thanks again for joining us. Hopefully that's been valuable for you as well. We have a special session next week where we are going to be taking a slightly different angle and looking at a tech perspective. We're inviting Stephen Bork from a company called Echo, who are a repeat or an online pharmacy effectively, going to be talking a bit about their journey, what they've seen in terms of patient behaviours and demographics and the tech response really to COVID. So thanks again for joining us, and tune in again next week, and have a good weekend. Thanks, bye-bye.
Thank you. Cheerio.